Perfect. Well, hello, everybody. Welcome tonight. We are so happy to have you here. My name is Dorian Chalmers, and I am on the board for the Minnesota Lyme Association. So I want to welcome you to tonight's presentation. Just before we get started, in case we lose some of you, we will have a support meeting next Tuesday night, which is the 16th of March on Zoom. And then next month on April 13th, we'll have Dr. Jonathan Otten, and he'll be talking about the testing that's coming out of Infecto Labs. And then May 11th, we'll have Dr. Linda Williams, who will be talking about the neuropsychiatric manifestations of tick-borne illnesses. She's coming to us from Seattle. So we're so happy to have all of these people coming up soon. But tonight, we are very lucky to have Dr. Samuel Shor. He is a clinical associate professor at George Washington University Healthcare Sciences. Developing his long-standing fascination of chronic fatigue in the late 1980s, Dr. Shor cultivated this interest in managing associated conditions such as fibromyalgia and ultimately Lyme disease. He has provided a congressional presentation of Lyme disease on Capitol Hill and has twice been interviewed on the nationally syndicated Diane Rehm Show and most recently on the Kojo Namdi Show. Dr. Shor participated on the 2010 Virginia Governor's Task Force on Lyme disease, is a past president of ILADS, and presently chairs the Loudoun County Lyme Commission. In 2011, Dr. Shor published original research providing evidence that the majority of his CFS patients in the study were actually presenting with seronegative Lyme disease. He is also the lead author in the 2019 ILADS consensus definition of chronic Lyme disease. Dr. Shor has a strong interest in educating the public and medical communities while actively involved in patient care. As such, he has been involved in the development of the Tick-Borne Illness Center of Excellence in Woodruff, Wisconsin. So we are so excited to have you here tonight, Dr. Shor, and I'm going to hand it over to you.
Thank you. Thank you for the opportunity to speak with you all. It's an exciting opportunity to provide now an educational experience and in Woodruff options for folks locally to seek care in the management of these often complex issues. The clinic has been open for a little over a year. We have a full-time nurse practitioner, Ashley Johnson, and I see 2 to 3 patients every day by telemedicine, Zoom, or equivalent. So we are seeing acute cases, certainly in the season more often, but as well seeing chronic folks and trying to provide this quality care to the region. Please feel free to reach out if anybody has any questions about the clinic. With that in mind, our talk today, I have no relevant financial or non-financial relationships to disclose, other than as to say I am an employee of the Tick-Borne Illness Center of Excellence, and as mentioned, past president of ILADS. So we are 3.5 hours east of Minneapolis, in northern Wisconsin, beautiful Woodruff. And this is the link that hopefully you'll have access to moving forward. The talk this evening, I'm going to briefly go over the manifestations of acute Lyme disease, go into a little detail about the article that we published last year defining chronic Lyme disease, and then discuss persister cells, and then briefly go over confounding conditions that are often comorbidities, biotoxin illness and mast cell activation syndrome. So although most of what the beginning pieces here are probably old hat to you all, I think it's worthy of comment that Lyme disease is generally presents as an acute viral-like illness that can evolve within 3 days, generally 5 to 14, but anywhere from 3 to 30 days after a tick bite, manifesting itself as joint pain, sore throat, etc. However, this acute viral-like illness actually can resolve spontaneously without antibiotics. And if not identified and not treated appropriately, can lead to chronic Lyme disease, which I'll mention in more detail in a moment. Interestingly, the development of this classic bullseye rash or erythema migrans rash you can see here, depending upon the series, can occur in as few as 20% of the cases in one series up to 80. So on average, we say roughly 50% of people develop a rash, so that you don't need to have a bullseye rash to have the diagnosis. And in fact, very often the rashes are in locations where one may not necessarily see it. You may develop it, but not see it, or it may be atypical. So that should not be a requirement to make the diagnosis of acute Lyme disease. Of course, the vector for this infection is the Ixodes scapularis in the Wisconsin region in the east, and Ixodes pacificus in the northwest. And you can see how small these ticks really are. In one series of over 1,700 children with Lyme disease, only 18% remembered having been bitten by a tick. And of course, the agent responsible for Lyme disease that is transmitted by that tick is Borrelia Burgdorferi. And Sensulatu species, that's the complex, the class of Borrelia that is involved. In the North American region, as you can see, it's primarily Borrelia sensu stricto and Meioni. In Europe, it's also sensu stricto, but also Guarinii and Afzelii, just for names for your next cocktail party. The seasonality of Lyme disease is an important component. And as you can see, the blue line is the exposure to the tick bite, and there's a delay of about a month, a few weeks, of the actual incidence of Lyme disease, so that the bites start to go up in the April, certainly May region timeframe. This is in the Northern Virginia area. And it may be delayed about a month or so in the Wisconsin, Minnesota regions because of the cold. However, this does peak in the summer and wanes in the early fall and winter, which does not mean to say that you can't contract Lyme disease any time of the year. You can, but the principal transmission is via the nymphs, and they are the more aggressive feeding entity of the different forms of the tick. But adults do feed during the winter months and can transmit disease as well. And as you can see, the reported cases are principally in the Northeast and the Wisconsin, Minnesota region. Aren't we lucky? That is an area that continues to grow in incidence, and there are various reasons for that, not least of which is that humans continue to build into the deer habitat regions where deer like to reside on the periphery of forested areas and what are cul-de-sacs. And the more we build cul-de-sacs, the more we build into the deer habitat and have risk of exposure to ticks. In fact, when I interview people about potential risk exposure, one of the highest risk activities is gardening. And if you think about the proximity that deers have to your homes. of course, walking in woods and tall grasses and all the rest are important pieces as well. With respect to chronic Lyme disease, this is one of my favorite topics. And I was the lead author in the paper that we published in 2019. It took several years for that to come to fruition, but fortunately it did. And the driving force that I personally had in initiating this project was this statement by the IDSA: chronic Lyme disease does not exist. To date, there is no convincing biologic evidence for the existence of symptomatic chronic Borrelia Burgdorferi infection among patients after receipt of recommended treatment regimens for Lyme disease. Unfortunately, we all know that that dogma is fallacious. Unfortunately, the literature doesn't support it. And we were compelled to provide evidence in the literature of a definition that in fact refuted that comment. And the other piece that's important here is, as I'll mention in a moment, there are two forms of chronic Lyme disease. One is that group who had received previous treatment, and there's another group who never were diagnosed. And in the IDSA statement, they don't even allude to those people who, for whatever reason, were never diagnosed. And we'll talk about that in a little bit more detail. Unfortunately, they describe people with what may be chronic Lyme disease as patients with unexplained chronic subjective symptoms following treatment with recommended antibiotic regimen for previously objective manifestations of Lyme disease. And in many patients, post-treatment symptoms appear to be the aches and pains of daily living, which is a quote people love to provide. Wormser had made that comment in the IDSA guidelines. However, ILADS defines chronic Lyme disease, and this is getting into our paper, and there are a number of caveats that I wanted to mention here, that chronic Lyme disease represents a multi-system illness with a wide range of symptoms and or signs that are continuously or intermittently present for at least 6 months. We had to identify some time frame. The illness is the result, and this is crucial, of an active and ongoing infection by any of several pathogenic members, again, of Borrelia Burgdorferi sensu. The infection has variable latency periods, meaning there can be delays of different time frames. It can wax and wane. It can be complex. However, in order for us to have included an individual in the analysis of this paper, they had to fulfill at least one of the following direct laboratory evidence criteria. What I mean by that is that these technologies are well accepted in the literature that, if positive, are indicative of an active infection. And so that any paper that we reviewed in order to be included in our analysis required at least one of these 4 criteria: culture positivity, polymerase chain reaction, which is looking at DNA or genetic material of the organism, antigen detection or specific proteins that are associated with the infection, or microscopy with a specific identification through immune markers. So any one of those 4 would have been appropriate, but at least one had to have been positive in order for that paper to be included. We reviewed over 250 peer-reviewed papers to extract the analysis that I'm about to go over briefly, and thus identified people in those 2 categories: previously treated and untreated, and then identified the clinical spectrum of those 2 respective categories. We called those groups CLD, or chronic Lyme disease U, that which had been untreated, and PT, that which had been previously treated. Just in general, Lyme disease is often characterized as the new great imitator because of the diversity of clinical manifestations. And I'm just going to touch on a few of them in today's talk. But we know that there can be a wide spectrum ranging from the cutaneous or skin manifestations vis-a-vis erythema migrans rash, or up through severe joint and neurologic issues, whether it be multiple sclerosis, peripheral neuropathies, autonomic neuropathies like POTS. So as mentioned, and it's important enough to mention again, the CLDU are those whose exposure was never clearly identified and thus represented long-standing untreated infection. And then there are groups of individuals who have been treated, but unfortunately was inadequate. Of the folks that we identified with untreated Lyme disease, there were 36 papers that we felt fulfilled the entrance criteria for analysis as mentioned, and that one of those four identifying markers had to have been positive. Interestingly, the top 6 symptoms that were described in that group through our analysis was joint pain, fatigue, sensory changes, a decrease or strange sensations, generally representing what we call peripheral neuropathies, headache, and joint swelling. In the next group, which is the CLD or previously treated group, there were very similar presentation, with the one difference is that instead of the joint swelling in the untreated group, there was impaired memory in the previously treated group. This has all just been generated by the numbers that we identified through the literature. That's how we came up with these 6 characteristics. The paper that we published goes into far more detail about the other clinical manifestations. So that the ILADS definition, another point that's important to make here is that we specifically wanted to identify BBSL or Borrelia Burgdorferi sensilatu as the cause, be recognizing that realistically, the majority of people with tick-borne illnesses have polymicrobial illnesses. What that means is poly or many microbial organisms, infections, pathogens. And that we realize that most people presenting with Lyme disease really have multiple infections. However, given the nature, the political nature of denialism in the medical community, it was felt by me and my co-authors that we wanted to fine-tune the definition such that we could really feel comfortable about the evidence and that it was irrefutable, as opposed to a nebulous sense of, well, you might have Babesia, you might have Bartonella. That starts to dilute out the evidence that we feel we provided. And frankly, in the 2 years that the definition has been available, I've never gotten a comment directed to me or the editors of the paper, as far as I'm aware, from anybody refuting our definition. So I believe that we were successful in generating this definition as described. But there are others in the literature who do look at the concept of chronic Lyme disease as a more complex multi-organism infection, as well. This was Dr. Horowitz, and this is Dr. Stricker, that do look at it as a multiple pathogen process. But there were different reasons why we generated the definition as mentioned. And I think that this slide pretty much goes over that. Now, I think that what's interesting is the concept of untreated or undiagnosed chronic Lyme disease has generated in my mind, or has been generated by this perfect storm, where you've got small ticks, you've got the clinical presentation, which is common, the diagnostics are poor, managed care is driving clinicians to see people in shorter periods of time, and then you've got the political overlay. So you've got a small vector, which very often can't be seen, and I've identified early in this talk that in this series of 1,700 children, only 18% remembered having been bitten. And those with erythema migrans rash range from 20 to 80% on average, about 50%. And again, it could be atypical. We have an expanding deer population, expanding ranges of ticks, and the ticks that are transmitting infections are becoming more and more frequently infected with multiple organisms. So more of them have Lyme disease and more of them have Lyme with other infections. And so that when people are exposed, they're often exposed and generate a more challenging clinical presentation that is challenging to treat. The clinical presentations, again, we're looking at why are people not diagnosed, because they're very often presenting with common complaints and very often look well. So that clinicians will say, well, you're a complainer and you are not as disabled as you're claiming to be, and your tests are normal, and go see a psychiatrist. Of course, I get patients from psychiatrists who are saying, there's something organic here, help me out. And what I'm hoping to do through the work that we're doing in the clinic and elsewhere is to train clinicians to be more sensitive, to be more aware of the reality of folks presenting with these conditions. And then, of course, managed care is a factor that affects many, particularly primary care, or most clinicians, that are driving them to see more folks within a briefer period of time, and somewhat shying away from the complex folks that require more intense investigation and management. And then you get to the diagnostics, where the two-tiered system, which, as most people listening here tonight probably recall, that the first part of the two-tiered system is the screening ELISA test, and that if the ELISA is negative, you stop. If it's positive, you do a confirmatory Western blot. Unfortunately, and that's the paradigm that's actually used for HIV, where the sensitivity of picking up HIV is greater than 99%. You're not going to miss it very often. Unfortunately, with Lyme disease, for various reasons, the sensitivity of this paradigm is really not adequate. It's hit or miss 50%. And that, unfortunately, there are many in the medical community who rely upon this as the gold standard, and claim, even in the setting where the CDC indicates that a test does not need to be positive for the diagnosis to be made, that very often Lyme disease is a clinical diagnosis. And in fact, they emphasize that not only does lab tests not necessarily have to be positive, but specifically CDC criteria does not need to be positive, because they're looking at population studies as opposed to identifying a diagnosis at the point of care. And then, of course, the political environment, as we've mentioned, is a challenge. Then moving to previously treated, This is a study by John Alcott, a colleague in Hopkins in Baltimore, with his SLICE study, which stands for Study of Lyme Disease, Immunology, and Clinical Events. And you can tell from this pie chart that, well, actually, a comment before that, and that is that in order to be admitted into this study, an individual needs to present with a bullseye rash within 72 hours of that bullseye rash. And they are entered in the study, labs are drawn, and they're started on antibiotics. And traditionally, it's doxycycline 100 milligrams twice a day for 3 weeks. That's the standard of care. That group is then continued to be studied over a period of time. And it's this statement that after 6 months, although 61% of people who were identified quickly, treated quickly with what is perceived as the standard of care by many, that 39% of people at the end of 6 months after having that criteria are still symptomatic. Now, am I saying that all of them have active infection? No, there are probably different reasons for this, but I would argue that a substantive number probably do have active, inadequately treated infection. And there are a number of studies, case histories, animal studies that support the concept that short courses of antibiotics in some people can lead to chronic active infection. I want to emphasize that, as mentioned here, that 61%, or the majority of people who are identified early and treated early with the 3-week course, seemed to do well, at least at the 6-month period. However, we're talking about those people who are going on to have chronic ongoing symptoms, and I'm arguing through this analysis that many of them have active infection. There are a number of mechanisms by which this occurs. There's impaired immune response. In fact, one of the phenomenon that occurs is that the body's immune system, when infected by Borrelia, has difficulty in generating the antibody response. Well, what is it that we're measuring with the two-tiered system? It's the antibody response. And that has implications on a number of levels, not least of which is that when an individual is more ill with Lyme disease, active Lyme disease, their immune system is working less well, they are more likely not to be able to generate appropriate antibodies. So paradoxically, the sicker one is, the more likely they're going to be blood test negative. And another comment relating to this, and I'm not sure I mentioned it, but I will now, and that is, you may all be familiar with IgM versus IgG. Let me just make a short comment about that. IgM is immunoglobulin M. It's an antibody. It's the first antibody that generally is produced by the body when exposed to a foreign invader. That usually peaks and then goes away. The IgG, or immunoglobulin G, then develops, and it is that latter marker that imparts immunity in many people. And as a result of that, there are many in the Lyme community or in the ID community who claim, in fact, it's a part of the IDSA guidelines, that if an individual presents with symptoms for more than 30 days, and it's the IgM that's positive as opposed to IgG, they say arbitrarily it's falsely positive. However, there is a plethora of evidence, and in fact, I published a couple papers supporting this, that in fact, the conversion from IgM to IgG is abnormal in the setting of Lyme infection. So in fact, the presence of IgM in chronic disease is a frequent phenomenon. All right, so these are other mechanisms by which this condition can become chronic. So there are alterations in the outer surface protein of the infectious agent Borrelia burgdorferi. Remember, now we're talking about the bacteria Borrelia burgdorferi. We're not talking about ticks. The tick just transmitted the infection. We're talking about the infection in the body and what that bacteria has the capacity to do. Immune sequestration, that means it's hiding. It can go into any one of these different types of cells, the heart, the nervous system, lymph nodes, etc. That one of the more fascinating phenomenon that I'm going to be talking about in a little bit more detail is this concept of persister cells, that there are round body, stationary or not relatively inert cells that can be generated. And in fact, I have, yeah, here we go, a picture. It's from an old Brorson paper that you can see on the left is the spirochetal actively replicating infectious agent that we think about of Lyme disease. However, when the organism is exposed to what we characterize as environmental pressures like antibiotics that can affect, for example, the cell wall, ceftriaxone, Rocephin, which is one of the classic drugs we use in IV treatment, goes after the cell wall. Well, interestingly, when this spiral organism gets exposed to that, it begins shifting over to the right to a cell wall deficient form that isn't impacted by ceftriaxone. However, fortunately, we are gaining more knowledge in how to manage this, and we'll talk about that in a second. The other form that can develop is a biofilm form whereby a matrix is generated by a colony of bacteria that's probably mixed with viruses and other infectious agents that are protected by the hostile environment of your immune system, of white blood cells, of antibiotics that can be protected by this biofilm. And our understanding of these nuances is helping us be able to treat people better, because what we're talking about is this concept of persister cells. And there are a number of studies that have been published, particularly out of Hopkins and Boston University, that are looking at these persister cells in the test tube and seeing what kind of effect different chemicals may have on these entities. And so, for example, oddly enough, in this paper by Feng, who's out of Hopkins in 2018, garlic was the most potent agent of the 35 essential oils to treat the stationary forms of Borrelia, of infection that I just showed you. This is another study by Feng a year earlier, and the three items on the bottom, oregano, cinnamon bark, and clove bud, were identified to be the most sensitive. And the way that's characterized is in the right column, alluding to the stationary persister cells, we're looking for the smallest percentage that's viable after being exposed to these agents. So that you can see a corollary of this is just above the oregano is doxycycline, and that only impacts 30% of the persister cells. And that's one of the drugs of choice that we historically think about for Lyme disease and tick-borne illnesses. but it's these other household agents that actually have more efficacy against these persister cells. In another study by Feng that's more recent here in 2020, Cryptolepis, which traditionally is an African herbal we use for babesia, actually has been shown not only to have good activity against these stationary round body persister cells, but actually also for the growing phase, the spirochetal phase, and Japanese knotwood similarly. Interestingly, looking down, actually, I think I talked about it. Yeah, it's the next slide. Serrapeptase is often used. It's an enzyme that, if you look at the far right, it eradicated biofilm. So it's a biofilm buster that was identified here in these in vitro test tube studies. It also actually has been shown to have good efficacy for the active spirochetal form. And that, interestingly, cat's claw and banderol have been shown across the board in all three forms: the active spirochetal form, the cell wall deficient round body form, and the biofilm form. They've been effective in all three. Here, there are a few other items to mention for completeness. Stevia is a non-absorbable sugar. And when I say cidal, that means it kills the bacteria, as opposed to static, which it slows down its growth. And this has been shown to be effective against both the active form and the round body form, and fairly effective for the biofilm form. Interestingly, if you look at the very bottom of the highlighted region, kelp or iodine does inhibit the spirochetal form, kills the round body form, and eradicates the biofilm form. And then, of course, there are those other intermediate range active agents, berberine, quercetin, and resveratrol. Now, Bartonella is also felt to create persisters, and that is beginning to be studied more aggressively. This is a 2019 paper by Lee, and also showing berberine effective for Bartonella, both the stationary forms and the log phase. And when I say log phase, that's the rapid replicating active form. The lower the number in that blue column, the more effective it is. The lower the percentage in the yellow column, the more effective it is. So methylene blue, folks may have been hearing about this. Rich Horowitz introduced this agent particularly in its use, particularly with dapsone. But rifampin is one of the drugs of choice for Bartonella, and the reason is it's very sensitive for killing the replicating form of Bartonella. But clotrimazole, which we normally think of as an antifungal agent, and berberine, which has a number of metabolic benefits as well, are both fairly effective in the stationary and log phase. Now, what about this disulfiram, new kid on the block? Well, the rationale for using disulfiram, which is a generic for the drug antabuse, is because of its effect on persister cells. And this is a study that looked at the effect of disulfiram and other agents in the test tube of these persister cells, so that the far left column represents no additional drug to kill the persister cells. So that's basically 100% persister. The next column, which is about 30% lower, is doxycycline, and that's in keeping with what we saw in one of the tables previously. Ceftriaxone, I'd mentioned, is one of the IV go-to antibiotics for Lyme disease and is getting you maybe 40% of the persisters, down to 40% of the persister cells. Vancomycin is a very potent IV antibiotic. You've got about 10% residual. Disulfiram eradicates the persister cells. It sterilizes the test tube. That was why we were so excited about that as a potential additional weapon in our armamentarium to treat Lyme disease. But there are some caveats that people need to be aware of. Some people are exquisitely sensitive to this agent, and that we have learned that we need to start low and go slow, and otherwise you can really become toxic. There are also a number of side effects that are primarily neurologic that can be generated by this medication, which is another reason to do things slowly, because if you start noticing, for example, encephalopathy, that means abnormality of brain function, that if a person becomes cognitively impaired, their behavior becomes abnormal, then we want to stop this drug right away. And I've seen that happen. And it can wash out and you potentially can resume it, but at lower doses, but you just need to be very cautious. Therapeutically, there may be profound benefit that could be sustained, and Ken Ligner has published on this. And we feel that there probably is sensitivity at least to Borrelia or Lyme disease and Babesia. Bartonella is a little less clear. I believe some people it does have some value, but it's inconsistent. So it's not as across the board. Okay, that's chronic Lyme disease. And this is an overview of a paradigm that I'm just going to briefly go over because it's the last few slides of the presentation. This is from the publication that I generated in peer review in 2011. And what I tried to do here, it's pretty busy, but if you look at the central core of the notations within the framework of the slide, it says the neurologic system. That means the nervous system is the central core of clinical presentations. This is a neurotropic condition. Tropism, it's drawn to neuro, the nervous system. So if you read the different categories, central nervous system, cognitive impairment, psychiatric, mood disorders, sleep, fractured non-restorative sleep, pain with or without fibromyalgia. And then above that, those categories are the autonomic nervous system, which is the part of the nervous system that controls unconscious function, blood pressure, heart rate, gut function. That's where a category of POTS, for example, would be included. That stands for postural, orthostatic, tachycardic syndrome. And those are fancy terms for the following. Postural and orthostatic means simply change in position. Tachycardic means rapid heart rate. So when someone stands up, their blood pressure drops, their heart rate goes up. They may or may not pass out. They may or may not feel uncomfortable, but that's POTS. And then I also mentioned the hormone system and the immune system and mitochondrial dysfunction. The reason I'm going over this is for the next couple of slides. And this is chronic inflammatory response syndrome, or CIRS, or otherwise known as biotoxin illness. And this is a concept that was characterized by Richie Shoemaker 10 plus years ago, whereby there were a number of clinical features that overlap with the presentation of Lyme disease I just mentioned. So if you read the purple columns, and it's hard, I apologize, the characterization of reading it is tough, but it says sleep disturbance, underneath that is chronic pain, under that is gastrointestinal problems, just to the right of that is prolonged illness, to the right of that relate to endocrine or hormone abnormalities. So you can see there are a lot of similarities between mold exposure and what can evolve as a result of that, as well as Lyme disease. And then actually, I'm not going to go over this right now. However, what I did want to mention was the mast cell activation syndrome. And mast cells are a part, you can see in the central portion of this picture, are a part of the immune system. And they're most commonly thought about as being responsible for releasing histamine. Histamine is a chemical, as you might imagine, is related to the allergy response. That's why we use antihistamines for allergies. However, this cell that releases histamine can release other chemicals. And as this picture represents, mold and Lyme disease can actually activate the release of these mast cells, so that the clinical features of over excess release of chemicals from mast cells can also relate to chronic fatigue and cognitive impairment and musculoskeletal issues and gastrointestinal issues. So there is a frequent overlap in clinical presentation, such that an individual who may historically have had Lyme may no longer have it and may have mast cell activation and or mold and or all of them, and they all need to be addressed. In relation to mast cell activation, a key feature in treatment is a low histamine diet that's outlined here. And there are different agents that we have available to us, such as something called ketotifen, which can stabilize and decrease the release of these chemicals, block the histamine effect, help sedate. But interestingly, when I've done research here, literature search, this agent that helps mast cell activation may actually kill Babesia, oddly enough. There's evidence that it may be effective against malaria, and we very often generalize that information related to malaria may often be generalized to Babesia. And then there are other agents that we can use to stabilize release of histamine in the gut, mast cell stabilizers, and other approaches to dealing with mast cell activation. Now, I'm sure this was a whirlwind tour of acute Lyme disease, chronic Lyme disease, and associated phenomenon. But the real reason for the talk today was to make people aware of the Tick-Borne Illness Center of Excellence here in Woodruff, Wisconsin, and I am open for questions. Thank you.
Perfect. So I should be back on here. For all of you out there, if you could put your questions into chat, that would be great. I'll start with one for you, Dr. Shor. In terms of disulfiram use, if someone is also dealing with mold toxicity, are you seeing issues doing disulfiram?
Interesting. One has to be careful of yeast overgrowth and alcohol generation within the gut, potentially. But I think as long as you're cautious with respect to what you ingest, they can be comorbid conditions treated at the same time cautiously, recognizing that a hallmark feature of treating mold is one, getting out of the environment, and two, binding agents. And neither one of those approaches should be a contraindication to disulfiram. Is there a specific question in relation to that in context?
I was just wondering if you just started dealing with mold toxicity, is disulfiram a good option in terms of if you've been dealing with Lyme for a long time,
Right.
you realize now that you have mold toxicity also, is disulfiram a good?
Yeah, I think my answer to that is one of balance and prioritization, as is going to be a component of any decision making. How ill is one with one issue versus another? What's the priority of intervening with one issue versus the other? And can that intervention create issues? And so that there's so much independent variability with any individual that it's hard to say across the board whether you should or shouldn't do anything like that.
Sure. All right. The first question we have for you is what is the cost of an initial consult at the Tick-Borne Illness Center?
That's a good question. It's I should have known that. It's in the 250, 300 range, thereabouts. I think it's 300. But call them to verify. I don't deal with the business aspect of things.
You don't do the paperwork.
No.
All right. Is there a reason why we feel worse during a full moon? And is there anything we can do during that time?
You know, it's interesting. I was reading one of these, and I'm not sure how valid this is. There was one comment I was seeing about parasites and the full moon. I don't know. Other than gravitational forces can change, I'm not aware particularly of that. I throw that as a wives' tale, but who am I?
All right. When will we get maps of other Borrelia species other than Borrelia burgdorferi?
Well, there are tick-borne relapsing fever, Miyamotoi, Borrelia miyamotoi is a different species. So I mean, we are getting that. And that's not a Burgdorferi strain. It's a different illness. So it is happening, but you know, some of this is surreptitious, and why are we able to diagnose one thing or another? It's just we have to continue pushing ahead with the research.
All right. What do you recommend for exercise when one has exercise intolerance?
Right, and that's a very fair question and a common concept with which I deal. I characterize the whole concept as one dealing with energy conservation, and have an analogy of a gas tank. And you've got a finite amount of gas in the tank. And what you want to do is think about proactively, what are your needs physically, emotionally, cognitively, and what are your energy reserves to be able to complete those needs. So you want to be as efficient as you can, and you don't want to push yourself such that you're halfway around the block and can't get back. You want to just think about common sense so that you're in a controlled environment. If you're going to exercise, for example, do it at home on a stationary bike. You can stop whenever you want, as opposed to getting out and walking around the lake and having difficulty getting home. But with time, that should improve if your treatment regimen is successful, and that usually is the case for most of my patients.
Do you think that we will someday be able to completely eradicate Borrelia from the body?
You know, yes. The fact that we're learning so much about the nuances of what's causing it to persist, these round body cell wall deficient persister cells, the the biofilm and learning how to better get at that, which are the mechanisms that contribute to that persistence, I have a positive feeling that I think we will. Can we do it now across the board? Not quite yet.
So that kind of answered another question about will people actually heal, or do they find that you need to constantly chase these pathogens?
It really depends. It depends upon your genetic makeup. It depends upon what organisms you're talking about. It depends about what comorbidities. Do you have mast cell activation? Do you have mold? Again, it goes back to that concept of having so many variables that some people can come in and be ill for a year or two, get treated with 6 weeks of doxycycline, and are well for the rest of their lives. Some people are treated within days of exposure and are ill for long periods of time. What is it in one person that makes it one way versus another? Again, there are so many variables, and we try to look at the whole picture when we manage folks.
Is the Tick-Borne Center in need of patients for research?
And that's a fair question. The focus, when we first started, we had a very strong focus on research. Things have evolved from a realistic standpoint. And although we are using metrics in managing our folks, and I'd like to think that we will analyze the data over time, it doesn't have the same proactive biobank approach that we initially had. So I'm going to answer that with a qualified, we're doing research on the patients we treat, but not research independent of that at this stage.
Will Woodruff support pathology research? There's a link to dementia. McCloskey and McDonald have good evidence linking to dementia.
Yes, and I'm going to say no, that's not the emphasis of the center. I understand that Brian Fallon at Columbia, for example, has a brain bank, so you may want to look into that.
Are there any new therapies to look forward to on the horizon at your center? I have heard a lot of buzz about SOT therapy, azlosilin, and Horowitz double dapsone treatments.
Yeah, I'm personally doing methylene blue and dapsone on patients. The disulfiram is new. SOT is a specialized approach that I'm interested in learning more about it, but frankly, it is not yet available there. I need to do more due diligence in order to feel comfortable with that possibility. But we are treating persister cells and using disulfiram and dapsone as well.
Thank you. Tips for those people who are super sensitive and herks at everything.
Yeah. Several concepts. One, look for mold. Start with that. Not uncommonly, I've got a handful of folks, you put one drop of one of these like cemento in a glass of water and just take a sip of it. And you herks on that. They'll herks on one drop. So you dilute it out. So you want to look at mold, you want to look at mast cell activation, you want to proactively detox and start low and go slow.
Is there a specific pathogen you correlate with muscle weakness and post-exercise malaise? And is this fairly common to see in Lyme patients?
Yes. And I'm not saying it's pathognomonic or specific to Borrelia, but I do think that it is not uncommon. I suspect you could probably get it with Bartonella and perhaps Babesia. That's not a slam dunk, and I don't think I've not seen any statistics that draw that specific complaint to a particular organism.
Is there a specific order that you would recommend addressing all the issues in? Example, detox first, then treat the gut, then Borrelia, etc.
Yeah, again, it's got to be very individualized. Clearly, the gut is a crucial component, and anybody for whom I anticipate treating with an antimicrobial, whether it be herbal or formal antibiotics, we're going to want to be cognizant of gut health and the microbiome, so that virtually everybody is on a probiotic, often on a prebiotic, and that if there are gut-related symptoms, we try to address those as well, whether it be leaky gut or SIBO or dysbiosis. We try to address those early on if it's an important clinical feature early on. Then virtually everybody is going to be educated with respect to different detox options, but recognize that not everybody is as sensitive as the next person. So that where just simply doing Epsom salt baths may be enough for one person, another person may need to take 5 drugs and start really slowly. Again, it goes back to that highly sensitive individual or not. And you don't know that until you talk to them. And then even then, if they've never seen anything before, you don't know until you start treating them. And you just do it cautiously.
Any suggestions for someone that wakes up at 2 to 3 a.m. wide awake and feeling good? Once I do go back to sleep, I feel much more drained of energy all day when I wake up the next time.
Yeah, it's half my patients. Yeah, what you've got is a circadian rhythm, delayed circadian rhythm disorder. What that means is the circadian rhythm is a normal 24-hour clock, and most people feel sleepy 9 to 11, 8 to 11 at night. But folks with the characteristics you just described don't start feeling tired until late or early in the morning. And that can create issues in terms of functionality and social involvement, etc. So, in fact, my last patient of today, I was dealing with that. And what we're doing is there are a number of agents that we can use as sedative hypnotics. And there are 2 or 3 I'll mention right off the bat. One is Flexeril or cyclobenzaprine. If someone has fibromyalgia, that's a really good go-to agent that is sedating and helps with pain. That ketotifen I'd mentioned here in relation to mast cell activation is sedating. And then there are other agents like Remeron or Seroquel if mood disorders are also of concern. But what I will do is actually, rather than start the sleeping meds at like 10 o'clock, that would be a standard time. If you're not falling asleep until 5, then what I'll do is start it at 2 or 3 o'clock in the morning. And every few nights, back it up 15, 30 minutes, so that as you're increasing whatever agent it is that you're trying. And to try to fool the system. Another agent that may be very important here is melatonin, which can help reset the clock. And sometimes I will also add light therapy in the morning.
Okay. What are your thoughts on frequency medicine and rifing? Have you had patients?
Yeah.
I do that too, it says.
Yes. I think there is something about energy medicine. I've used PEMF, pulse electromagnetic field generators. I have UV light therapy, actually, that can stimulate white blood cells and have antimicrobial activity, etc. I know that some people swear by the Rife. I think I think there's something about it. I would like to see more research about it. And the other comment is that there are probably variabilities in quality of machines, so that because there's not a lot of research about it, you may not know what's quality and what's not.
For our friend who's up at 2 to 3, we have a couple people who are ready to have a party with you. So just
go
so
for
you
it.
feel, so you don't feel alone.
Right.
Thoughts on keto diet for treatment?
Absolutely. Yeah, that's actually one of my recommendations overall, in terms of diet. It removes carbs, which are a substrate for yeast and Borrelia. And ketosis can actually generate an environment that is not healthy to perpetuate the infection. Or a flip turn is that it is healthier for you, the individual, to sustain a ketogenic diet and ketoacidosis. So yeah, I think that actually is a healthy approach.
Do you have experience or knowledge treating other pathogens besides LD, such as Campylobacter? This can present looking like Nero, LD, MS, or Guillain-Barré.
Yeah, that's a good question. I frankly, I normally think of Campylobacter as a GI pathogen. But you know, when you're treating one organism, you're often treating others that you may not identify. That tetracycline derivative, doxycycline, minocycline, or macrolides like Zithromax have broad spectrum activity against a lot of these bugs. And so that although clinically you may think you're treating one, you may actually be treating something else. Um, I Chlamydia is not something that I frequently search for, but I suspect I may be treating with what I'm otherwise using. Or was it Campylobacter or chlamydia?
Campylobacter.
Campylobacter, right. Well, see that they're both are C
words,
bacteria.
yes.
Right. Campylobacter, I do normally think of it as a GI pathogen. I normally don't think of that as a neurologic.
All right. Air hunger that has lasted a long time within long-term treatment.
Yeah. Well, particularly Babesia can be associated with this sense of not being able to take in a satisfying deep breath. That's a classic characteristic that I use on a daily basis to screen my patients to see if that is present or not. I believe functionally that represents a dysfunction of the diaphragm. So if you think the diaphragm is at the bottom of the lungs and it contracts to create negative pressure, if instead of going like this, it's going like that, I can't take in a satisfying deep breath. That's a common feature of Babesia. And what I ask to distinguish, for example, between that and asthma is that asthma is more difficulty breathing out. This is more difficulty breathing in.
So if they've had long-term treatment for tick-borne illnesses,
it should go away. I mean, if your Babesia is being treated, I mean, having said that, there are some people who have sequelae or long-term residual effects of some of the abnormalities that can be generated during the infectious stage. I normally think, for example, of POTS and autonomic dysfunction as often having residual abnormalities when you check the blood pressure and heart rate at a point when we feel clinically someone is no longer actively infected. They may still have some abnormalities, but it usually doesn't create clinical issues for them. But then again, it goes back to the statement that this is so individualized that for an individual, they may theoretically have long-term sustained dysfunction of diaphragmatic contraction. Theoretically.
And
I've not seen that. I've not seen it.
there's no way
long-term.
to mitigate that with some sort of like physical therapy to.
Possibly. I mean, there are diaphragm stimulators. If in fact, I've never seen that used in this setting. But very often we have to think out of the box. And if in fact what is going on in this individual is as I described, then that is a possible consideration.
Interesting. Well, thank you. Any recommended treatment for inflammation due to chronic Lyme? 20 plus years. Have you been able to help any patients like this? I have only found some relief by eliminating dairy, gluten, sugar, and nightshade veggies.
Yeah, again, it's individual. Have you ever been treated? Clearly, the gut is an important component. Are there any other comorbidities, mold or otherwise? And have you been adequately treated for the underlying infectious process? Would you benefit from immune support like with low-dose naltrexone? I mean, there's a lot of stuff that potentially could be brought to bear.
Your thoughts on effectiveness on herbs versus antibiotics?
Well, particularly in light of the persister cell work that I alluded to in this talk, that dovetails very much into the approach that I've taken for a decade. And that is in my 2011 publication where I talked about the majority of my CFS patients having Lyme disease. I found that when treating with antibiotics, they got better, removed the antibiotics, they had relapses. I subsequently learned that by using different herbals, I was able to suppress and decrease the tendency for the relapse. What I'm doing now, in addition to that, is introducing herbals earlier to deal with the persister component, to deal with the biofilm component, and in some cases to deal with the overall infectious piece without formal antibiotics in some people, particularly if that's their frame of reference and they prefer that. So yeah, I think that there's a crucial component. I mean, if you think about the slides I showed, garlic, it was one of the most potent agents. Stevia or berberine or monolaurin I didn't have up there, but that's coconut oil. I mean, these all have potential value in the right setting.
Thoughts on levator reticularis? Thoughts on hair loss and inflammation, red, painful scalp?
Libido, I think, is a manifestation of autonomic dysfunction primarily. It's the mottled skin that you get in the lower extremity, particularly often with cool extremities. Sometimes you can help that there may be a component in some people with fibrin deposition. So using Baluch or serapeptase may potentially help. Treating the underlying infectious issue usually helps, but I not uncommonly see that.
Mold is everywhere. How do you minimize?
Don't breathe. I know, I mean a little tongue in cheek, but it's a matter of common sense, and avoid water damage. If you are able to identify areas of concern that you remediate or leave, if you can. And I know there are some people where that's a frustration because for various reasons, financial or otherwise, they have difficulty doing that. But if you have the capacity to remain in a clean environment, then it's important, particularly if you're genetically predisposed to having difficulty with that issue. And I don't necessarily test people for Shoemaker's genetic markers necessarily, because it is what it is. But from a concept of sensitivity, I think it's important to understand there are some people who are more sensitive than others.
Do you treat children with Lyme and co-infections? Any tips?
I'm an adult physician, and I will treat as young as 15-ish. But so no, not beyond that. Sorry.
Thoughts on uveitis, eye red, and painful?
Yeah, can be due to Lyme. There are other causes, viral or otherwise. But I think you need to be seen by an ophthalmologist and have them be an active participant in your care. And if it is due to tick-borne disease and Borrelia, then you may need to be more aggressive than less aggressive under those circumstances.
Do you have recommendations for ways to find mold or companies to call? I have a mold guy.
Okay.
I've actually used him twice in the last 3 months, once for my house and once for another house. So
why don't you forward that information to the group?
Yes, I will do that.
And myself included. I'm always looking for resources.
Yeah, he's terrific, and he works with a lot of the functional medicine docs, a lot of our Lyme docs in town too. So I will put it into the chat for everybody. It's his name. It's called Green Home Solutions. His name is Charles Clark, but I will type it into the chat. I think he's terrific. So, do you work with genetic reports to determine treatments?
I don't. I think they're unwieldy, and like the MTHFR mutation, and I mean, there's maybe some value in some of the COMT, etc. But frankly, and there are many of my colleagues who agree with me that I don't emphasize that piece particularly.
All right. I have not had an appetite for many years since having chronic Lyme. More recently, I have found I have an appetite for a short time after taking probiotics, doing an IR sauna and acupuncture treatment. What does this mean? I have been following an herbal protocol for over 2 years and I'm doing much better.
Right, right. Well, it certainly sounds like the gut is your Achilles heel, and that aggressive management of the gut. It sounds like you may have been dealing minimally with dysbiosis, but there may be leaky gut and SIBO, et cetera. And so that core needs to be adequately managed, and then think about the other contributing factors that may be playing a role in your systemic issues, whether it's infection, mold, or otherwise.
Thoughts on hair loss, helpful treatments, and what might help in red, painful, inflamed scalp?
Yeah, I'm not sure about the scalp piece. Hair loss, usually the majority of people with hair loss, it is a self-limited process, usually. Obviously, some people it's not, and depending upon the type of hair loss, I'm talking about that which is stunning the hair because of a stress, a trauma, an illness, that usually 6 weeks, 6 to 12 weeks after an insult, you may have hair loss, and then it starts to grow back again. Sometimes there are other factors like hypothyroidism, but the vast majority of people, when they have hair loss, it's self-limited and because of some insult that then resolves spontaneously.
How do you feel about people with chronic Lyme getting the COVID vaccine? Anything to do to prepare, pros and cons of each?
Yeah, boy, I get that every day at this point. My attitude is this. In general, prior to COVID, I was very cautious about my active Lyme patients getting vaccines, because if you think about this indolent infectious process where the immune system is on a hair trigger to try to clear it, and that a Herxheimer response represents an inflammatory cytokine storm, what are we doing when we introduce vaccines? We are introducing a stimulus to the immune system, which already is on a hair trigger. So, unrelated to COVID, if one was unstable, I generally recommended trying to avoid vaccines. Definitely avoid live attenuated vaccines like chickenpox and the old shingles vaccine, not the new one. However, and this is the caveat, COVID is a different animal. People die from COVID. And particularly if your immune system is compromised, as it often is in Lyme disease, my personal attitude, weighing on balance the risks and benefits, recognizing that any one individual may destabilize their Lyme disease, but may save their life, my perspective is to do it. And then you may ask which one. And I'm generally recommending, if you have the capacity to do J&J because it's a single shot, and also for children of childbearing age, there are some risks I understand from the other two, that there can be sequelae as a result of that. So I am recommending virtually everybody get the vaccine, and preferentially the J&J.
I was on a call with GLA. The one thing they said to do about preparing, one of the docs recommended, and it probably a lot of the Lyme people are on this anyway, 2 weeks prior and 2 weeks after the shot, they should be on A, C, D, vitamins, fish oil, glutathione.
Right, glutathione, NAC, yeah, zinc. Yeah, there are protocols that we have. Some of that is in relation to protection if you get exposed before you get the vaccine. There are prophylactic protocols. What you're alluding to, and you may or may not have meant to say this, is preparation for the vaccine specifically.
Yeah.
And I think that there may be some value in immune boosting and decreasing the cytokine storm that could potentially occur by having NAC and or glutathione on board, or the equivalent. There may be some value to that.
All right, infrared versus ozone sauna for detox.
Yeah, well, ozone's not going to detox. Ozone's going to kill. I mean, generally, I have hyperbaric oxygen center in Virginia, so it's somewhat similar to the ozone concept of oxidative stress. And although there is some potential health benefit as opposed to killing benefit, you need to be careful that you may actually cause a Herxheimer reaction with ozone. And the same with IR, whereby there are a couple caveats with IR sauna. One is you need to make sure that you're adequately hydrated, because between the perspiration, which is what's getting rid of the toxins, and the vasodilation of the heat, your pressure could drop, particularly if you've got autonomic dysfunction like POTS. You need to really be careful about how long you're in there and how well you're hydrated. So I wouldn't go in for more than 5 or 10 minutes, at least until you get a sense of how you tolerate it, and generally no more than 20, 30 minutes. The IR, and generally you think about going in a sauna for detoxing. IR can kill the bacteria. So you can Herx if you go in and you've got IR as well, infrared.
I'm going to ask one last question because we're almost at 8 o'clock here. Any detox recommendations from you?
Yeah, I have a list of things from Epsom salt baths to glutathione to NAC, berberine pinella, curcumin, cytoquel, um, Alka-Seltzer Gold or Arm& Hammer baking soda equivalent. And there actually is a comment that I want to make about that last option. When we provide baking soda, we're alkalizing or raising the pH in an individual. Borrelia likes an alkaline environment. So although there is value in this, it needs to be done carefully. And the rationale for using baking soda for a Herx reaction is we feel that a Herx generates an acidic environment, a lower pH. So that what we want to do is just give enough baking soda to neutralize that and get away. You don't want to use it on an ongoing prophylactic basis like you do with other agents like glutathione or NAC. It can potentially be very helpful in the acute setting as long as you don't overdo it.
Fabulous. Well, I think it is 8 o'clock and we have taken up a lot of your time. If everybody can, those who can quickly unmute themselves, just hit your unmute. I can't do that, unfortunately, for you, but if you can unmute yourselves. I would like to give Dr. Shor a big round of applause.
Thank you. Thank you.
Thank you so much for being here. This was so informative. And I know that we will be posting this on our website. I can't tell you when. We send it off to the webmaster. Don't know quite when that will happen, but so do take a look if you are there things that you want to look at again, or you want to send your friends to it. It's under our events on mnlyme.org. For any of you who just joined us, haven't joined us before, if you want to get e-blasts about our upcoming events, go to mnlyme.org and you can sign up to get those e-blasts on the bottom of our homepage. Once again, we'll be having a support meeting next Tuesday. That is on there. Next month for our presentation meeting, the second Tuesday, we'll have Dr. Jonathan Otten, and in May, we'll have Dr. Linda Williams. So Dr. Shor, thank you so much. Thank you for being part of the Tick-Borne Illness Center of Excellence. It's so great that we have a facility like that so close to us. It's not really that far. It's 3.5 hours from the cities, you know, here in Minnesota. And so if anybody's taking a trip, I'm guessing they can go at least check out the outside of the building. I heard it's beautiful. I heard it's beautiful. So
that's what I understand. Yes.
Yeah, so thank you so much for all the work you do, and everybody stay happy, stay healthy, and I hope that we see all of you again really soon. Thank you so much.
All righty.
Bye.
Good night, everybody.
Bye.